This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara. Today we're looking at a fascinating new study from Health Technology Assessment, published in 2026. It's a synopsis from the SPRING RCT, focusing on a topic we handle daily, seizure prophylaxis in glioma surgery.
This is a perennial debate in the scrub room, Alara. We know that for our patients with glioma, seizures aren't just a symptom. They are often the most debilitating part of the disease. What does the SPRING RCT synopsis highlight regarding the sheer scale of the problem?
The numbers are quite striking. The paper notes that in patients with a glioma, between 50 and 80% will experience seizures during their lifetime. But here is the real challenge for us as clinicians. Half of these patients will have seizures that are drug-resistant.
That 50% drug resistance rate is exactly why the timing of our intervention matters so much. If the medications aren't working for half the population, we have to be very strategic about when we are most concerned. Does the paper specify the high-risk periods?
It does. The study identifies 3 critical windows where seizure risk is significantly increased. First, and most relevant to our surgical team, is perioperatively, right around the time of surgery. The second is at the time of tumor progression, and the third is shortly before death.
Right. The perioperative window is where we have the most control, but it's also where the most controversy exists, especially for patients who haven't had a seizure yet. What did the synopsis find regarding the seizure-naive patient, the one coming to us for an initial resection who has never had an event?
This is the core of the clinical dilemma. The paper explicitly states that in seizure-naive patients with glioma undergoing surgery, existing guidelines do not recommend the routine use of prophylactic antiseizure medication.
And yet, if you walk through any neurosurgical unit in the country, that isn't necessarily what you see in practice, is it?
Exactly. The synopsis points out a major disconnect between guidelines and clinical reality. It notes that, despite those recommendations against routine use, an anti-seizure medication, specifically levetiracetam, is frequently prescribed perioperatively in many neurosurgical units.
It's that better safe than sorry mentality, even when the evidence isn't quite there yet. Levetiracetam has become almost ubiquitous in the perioperative setting because of its perceived safety profile compared to older generation drugs. But the SPRING RCT is really pushing us to look at the evidence for that prophylaxis.
It really brings up the question of whether we are over-treating a population that guidelines suggest don't need it, especially when we consider that 50% will eventually face drug resistance anyway. The study frames this as a synopsis of the trial, suggesting we need to be more rigorous in how we apply these guidelines to our surgical planning.
It's a vital reminder for the residents and students listening. Just because a practice is frequent doesn't mean it's evidence-based. We need to weigh that 50 to 80% lifetime risk against the specific recommendations for the seizure-naive patient.
Precisely. The SPRING RCT synopsis serves as a call to reevaluate our routine perioperative protocols and align them more closely with the data, particularly concerning levetiracetam use in those who haven't yet presented with a seizure.
Well, that's a lot for our listeners to chew on before their next clinic. Dr. Alara, thank you for breaking down the SPRING RCT synopsis for us.
My pleasure.
To our listeners, thank you for tuning in to the Neurosurgery Hub. Stay evidence-based, and we'll see you in the next episode.